All right, so got the cardiac cycle. The cardiac cycle is what the actual heart is doing, okay? What the chambers are doing, what the valves are doing. Everything else, we've looked at the individual parts and pieces of how electricity moves through, what happens to the myocardium. Now we're looking at it on a bigger scale, okay? What are the chambers doing? What are the valves doing? When we look at the cardiac cycle, guys, it is all the events. Again, this is accumulation of everything. How the electricity gets initiated, how it moves through the myocardium, when the myocardium contracts. What the hell is that? That is systole. When we repolarize, we relax. That is diastole. Okay. Blood's going to move from high to low. I hope that makes sense. I mean, to me it does. I'm not going to get into it, but it does. We have valves. Valves ensure that fluid doesn't go backwards through the system. So again, this is what the actual chambers and valves are doing. When it comes down to it, the most important aspect of all of this is going to be ventricular action. To be quite honest, I could give two bits what the atria are doing. They are so small. They don't hold a whole hell of a lot of blood. They don't push blood through the system. They don't push it through the pulmonary system. They don't push it through the systemic system. It is the ventricles that are doing the heavy work here. So it's really the ventricles that ultimately we really care about to make sure that you don't have some kind of heart failure. When it comes to those ventricles and what they're doing, it's the AV valves, okay? When the ventricles contract, the AV valves are going to be important because they are going to be preventing backflow of blood into the atria. And again, papillary muscle, chordae tendineae are involved in that nonsense. The way the semilunar valves are shaped, it allows all of that force that's generated by the ventricles, it allows them to be easily pushed open and blood ejected through them. When the ventricles relax, ultimately the semilunar valves will close. Again, their cusp shape there as blood starts running back, fills the cusp and shuts it up. And as the ventricles have been contracting, the atria have been relaxing and filling with blood. So eventually you're going to have too much pressure on that side of the chambers and negligible pressure inside the ventricles. And those AV valves will open up. Okay. So let's look at all of these 5 different steps. Okay. Oops. Okay. There we go. All right. This is where we're going to begin. Now, so let's see something here. Okay. This is where we're going to begin. Okay. This is where we will begin the events of the cardiac cycle. So if you are explaining this on an exam for a short answer question, this is where you begin. Some textbooks will refer to this as late ventricular diastole, but this book doesn't. Okay, so I'm going to use this book. All right. So if you have some other book that you're reading for whatever reason, just be aware that this book doesn't utilize that terminology. It's actually a little bit different. There's a handful of things that are changing in the realm of A&P, and this is kind of one of them. So there are some subtle differences compared to this semester from semesters past. So as the cardiac cycle begins, everybody's at rest, okay? The ventricles have basically ejected the blood and they are relaxing, okay? Blood is being pushed forward through the system, okay? and let's just talk about systemic flow. Been pushed throughout the ventricles, through aorta, through all the little systemic arteries. It's coming back in systemic veins, and blood is returning back to the atria. The ventricles are relaxing, so this is really passive. Okay, this is what's going to happen passive here. If the ventricles are relaxed and there's negligible blood within them, because it's not 100%, all the blood has been pushed to the atria, forward through the system. So all the blood is going to be filled in those atria. So I have a very high amount of pressure because of all that volume of blood within the atria. And it is that pressure, high in the atria, very negligible and low within the ventricles, that forces those AV valves open. Okay. And the ventricles start to fill with blood. Semilunar valves are closed. Why? Well, blood was coming back towards the ventricles because there was no pressure within them anymore, and it shuts them up. Right? Plus, think of the semilunar valve as a hole in a bucket. If it's open, the bucket can't fill. Right? And the ventricles wouldn't fill. So think of it that way, if that helps. Right? So this is where we're at. Everybody's relaxing. Okay? The only reason why the blood moved from the atria to the ventricles is the change in pressure, the huge difference in pressure because of all that volume of blood within the atria and really nothing within the ventricles. Everybody at rest. Everybody is in diastole. AV valves are open. Why? Because the greater pressure within the atria, because of the greater blood volume within it. Pushes those AV valves open and the ventricles start to passively fill with blood. Semilunar valves are closed. Then we head to step 1. Atrial contraction. Okay, we just established that nobody was contracting here at the very start. Very fraction of a moment in time. Greater volume of blood, greater pressure, opened up. Now, as soon as that thing starts to dump all its blood out, now we're going to initiate this contraction. Who does that? Mr. SA node, right? So we're putting it all together. That SA node triggers the electrical activity for that atria to contract. Travels across the internodal pathway, down to the bottom of the AV node. As it's traveling down through the atria, it's causing the atria to contract. Step 1, I mean, it's in its name. So, I mean, I don't know what to tell you. Okay. Atrial contraction. Atria contract. Okay. If you want to use fancy words, you can say systole. All right. This is generally referred to as atrial systole in most textbooks, but for whatever reason, this one's not. Any remaining blood that's been, again, going forward through the system, entering into the atria, any blood that has entered into that atria gets ejected into the ventricles, gets pushed into the ventricles. Okay. The ventricles are still passively filling. They are relaxing. Okay. Ventricles filling, passive. Okay. It's still passive. Right. They ain't doing jack squat. And the ventricles ultimately get filled to their end diastolic volume. And we'll look at that number here in a little bit. As soon as the atria contracts, what do? They relax. And then really we don't see them again until until we start this whole nonsense over again. They're done. Okay. They are done. So that's step 1. Step 1, atriosystole. Atria contract. Any blood that got pumped into it forward from the system gets pushed into the ventricles. Ventricles, ultimately get filled to their end diastolic volume. AV nodes are obviously open. I'm sorry, AV node. AV valves are obviously open. Semilunar valves are obviously closed here. As soon as they contract, they relax. Peace out, they're done. That takes us into step 2. Isovolumetric contraction. When the ventricle contracts, it contracts in 2 phases. It initializes the contraction, and then it contracts. All right. So isovolumetric is just the initiation of ventricular systole. Ventricles contract a little bit, but really it's not enough to eject blood. Okay, hence the term iso. Okay? Like an isometric contraction. Muscle shortens, but there's there's contraction, but there's no shortening of the muscle belly itself. Just an engagement of actin and myosin. And that's kind of basically what we have here. Okay, we have the initiation of the ventricles contracting. So ventricles initiate their contraction. Okay, initiate and then contract. Initiate, contract. Initiate, contract. That's what we have here with ventricles contracting. So in step 2, it's isovolumetric contraction. What is contracting? It's the ventricles. Okay. Again, we just established atria and doing jack squat from here on out. So it's the ventricles. All right. It's enough to increase pressure a little bit to basically force the valves closed. And by valves, I mean the atrioventricular valves. It's just an initial rise in pressure, nothing more. Shuts the AV valves up. It's still not enough to eject blood. So if it's not enough to eject blood, semilunar valves are still closed. So in step 2, atria are in diastole, ventricular start to initiate systole, all the valves are shut. AVs push closed, semilunar is still closed. Step 3, the ventricles finish their contraction. Okay, this is when blood gets ejected out of the ventricles. Okay, so if blood is being ejected out of the ventricles, my semilunar valves are forced open. AV valves are still closed. Okay, AV valves closed right here in isovolumetric, and they stay closed here. I didn't write it down. I just assumed you would know it. So if you want to write it in the sideline there, atrioventricular valves still closed. Atria still relaxing. They don't really do a whole hell of a lot. When the ventricles contract, they eject a certain volume of blood. We call this amount of blood that the ventricles contract as stroke volume. Okay, and stroke volume is just the blood ejected by the ventricles. That's all it is. Okay. And stroke volume, as you can kind of see down there, is around 70 milliliters. The end diastolic volume, the amount that the ventricles completely fill with, is around 130 milliliters. So you can see not all the blood is ejected. Okay. There is nothing in the human body that is 100% effective. So it just makes sense that this wouldn't be as well. There's a little bit of blood that remains, and that's the end systolic volume. Systolic means contraction. So after contraction, the amount of blood that still exists within the ventricles is around 60 mils.
I'm confused about the end diastolic versus the end systolic.
Diastolic is at relax. Okay. So when the ventricles are relaxed,
But they both have to do with a volume in the ventricles.
C, volume of blood. Okay. The atria are very small, yes? And the ventricles are very big. The amount of blood that's in here is just going to be a drop in the bucket here. Okay? Just a drop in the bucket here. The end diastolic volume is always going to be bigger because the ventricle does not pump all of it out. It doesn't pump every single milliliter of blood out of it. There's 60 milliliters that are within it. Okay? So it doesn't pump everything out of it. This little bit of volume that stays in there ensures that really that the ventricle does fill up when it is in this atrial contraction isovolumetric phase. Okay. So I have the end amount of blood found within the chamber of the ventricle is going to be big. 130 milliliters. The amount of blood that usually gets ejected in the normal individual is around 70 milliliters, and that is referred to as your stroke volume. If you subtract those two, that gets you your end systolic volume. At the end of ventricular contraction, there is still 60 milliliters that is left within the chamber.
Okay, thanks.
Okay. And as long as you remember systolic and diastolic, systolic is contraction, diastolic is relaxation. So the amount of blood, the volume of blood in the ventricle, when it's done completely relaxing, is 130 milliliters. The amount of blood that the heart ejects out, the amount of blood, the volume of blood that gets ejected by the ventricles is 70 milliliters, and that is the stroke volume. So the remainder that stays within the ventricle is the end systolic volume. At the end of ventricular contraction, there is still 60 milliliters in. Okay, that's what those numbers are. It just ensures that the heart fills up. Then it opens Pandora's box of why then is it that big? Why can't we just have a slightly smaller heart? Well, I don't know, because that would really affect heart rate and stroke volume and some stuff that will affect cardiac output, and we would be different. Okay, our physiology would be a hell of a lot different. Okay, that 70 milliliters, effective, purposeful, sufficient to get enough oxygenated blood to the brain and to everything else. So we have atrial contraction or atrial systole. I have isovolumetric ventricular contraction. I have the finish of the ventricle contracting. And now I have isovolumetric relaxation. It's contracted and it starts to initialize the relaxation. Okay. That's all it is. Okay. Pressure is still great within the ventricle compared to the atria. And it just slowly relaxes over time there. Right. As this thing contracts and starts to relax slowly, blood that didn't get up and over the pulmonary trunk or blood that didn't get up and over the aortic arch starts to rush back towards it. And again, those semilunar valves close. Sorry. Let's see. Yeah, mess up here in the notes. Okay. Ventricular pressure, still greater than atrial pressure. So sorry, I didn't see that before. It's because that ventricles is just beginning the relaxation process, all right? And because the ventricular pressure is still a little bit greater than the atrial pressure, the AV valves are still closed. Okay. This kind of continues the notion of ventricles relaxing, atria relaxing. This is diastole of everybody. Atrial diastole, ventricular diastole. This is late ventricular diastole, generally what this is called. But for whatever reason, they're changing terminology. Okay. During the fifth phase of atrial relaxation, all heart chambers are relaxed. I mean, the ventricles are relaxing. They're completing their relaxation. And we start the whole thing over again. First step, atrial contraction, ventricular filling. What's happening? Well, the atria are contracting and the ventricles are relaxing. Pressure was great within the atria and it forced the AV valves open and all that volume of blood came down here into the ventricles. Semilunar valves are still closed. Pressure is still great within the system. Isovolumetric. Atria relaxed. Ventricles initialize the contraction sequence. This increases the pressure just enough to force the AV valve closed. Still not enough force to eject it through the system, so my semilunar valves are still closed. Ventricular ejection. Ventricles contract. Again, AV valve still closed. Semilunar valves are open. I am ejecting the blood out. I am contracting the blood out. Ventricles are contracting here. Isovolumetric. Blood volume pressure within the ventricle drops. This is enough to initialize that blood not getting up and over the pulmonary trunk or up and over the aortic arch to start rushing back, closing the semilunar valves. This is a fraction of a moment in time. Semilunar valves, atrioventricular valves are closed as well. The ventricles are still relaxing. The atria are relaxing. Blood is greater here in this chamber, pushes open those atrioventricular valves, and the pressure starts to rise. Then the atria contract because the SA node told it to. Pushes any remainder blood that was in it into the ventricles. Again, AV valves open, semilunar valves closed. Then the atria relaxed and the ventricles initialized the contraction sequence, closing the atrioventricular valves, but not enough to eject the blood, so my semilunar valves are closed. Then the ventricle completes the contraction. AV valves still closed, semilunar valves are now open, and blood is going forward through the system. As the ventricles start to relax, that's isovolumetric, blood comes rushing back, closes the semilunars. Brief moment in time where these these volumes are going to be equal, these pressures are going to be equal, and the AV valve is still closed. Ventricle continues to relax, pressure drops within it. Greater volume in the atria causes the AV valve to open up. All that blood comes rushing into the ventricle, and then it finished. And then you see, we just keep going over and over and over and over and over again. If you can sit there and talk about what the chambers are doing, what the valves are doing, okay? Because that is what the cardiac cycle is. It's what the physical structures are doing. Could you coincide all this nonsense with what happens within the internodal pathway, the nodal cells, and what the myocardium is doing? Sure, yeah, you can. Atria contract because the SA node depolarized. Sent that wave of electricity through the chambers, through the atria, down towards the AV node. Atria contract. AV node, a little bit smaller, fewer gap junctions, ensures that atria contracts to completely fill the ventricles. As that electricity moves from the atrioventricular node to the AV bundle, down the bundle branches, Purkinje fibers, we are initializing the action of the myocardium within the ventricles. As it travels through the myocardium and contracts, it ejects. Then we repolarize and we start to relax. And then we have all the nonsense down here occurring. So we looked at all of them individually. But could you weave a big story together? Probably. I know you can. You guys are smart. You guys do well on exams. Would I ask a 30-point question like that? Probably not. But boy, if you could write all that stuff down when you're studying this nonsense, connecting dots, whew, get chills just thinking about it.